Hi, I'm Stacy Hunter, and we're on the last part in our 4-part series on thorax and abdomen. So let's start with those posterior wall muscles. Okay, so we've got the Quadratus Lumborum, psoas major and minor, and the iliacus, making up our posterior wall muscles. The Quadratus Lumborum, shown in green, goes from our iliac crest to the 12th rib and its transverse process of T12. So it's innervated by the ventral rami, and this is what's important for lab. The subcostal iliohypogastric ilioinguinal nerves lie on top of it. There's also a psoas major and minor. That's our next muscle. Now, not everybody has a psoas minor. It's not really important, but they would have a psoas major, so don't get worried if you don't see it in lab. But they lie on the lateral surface of T12 to L5 vertebrae to the lesser trochanter, so it's going down to our leg. It's also innervated by the ventral rami, and it's important to note that the genitofemoral nerve pierces psoas major. Iliacus, it's sitting right there in that iliac bowl, I like to think of it. So it's from the iliac fossa to our lesser trochanter, just like psoas was, going to that lesser trochanter. It's innervated by the femoral nerve, which is different from our other two, innervated by ventral rami, and lateral femoral cutaneous and the obturator lie on top. So the femoral nerve pierces this muscle, so it's also lying there as well. So we've talked about the diaphragm. There's also some posterior attachments that we need to talk about, and these are important to know for lab. So they're color-coded here on the picture, and the median arcuate ligament is what's in the middle. And so look, it ends with an AN. This is important because the next one is the medial arcuate ligament. And so these ligaments are really similar in names, so they want to make sure that you know the difference between the two, so that's why that they could ask a question about this. So median lies in the middle, and then medial is lying lateral to the median, but it's more medial than lateral, if that makes sense. And then our lateral arcuate ligament is on the outside. So posterior to the median arcuate ligament is the sympathetic trunk. The psoas passes under the medial arcuate ligament, and the Quadratus Lumborum passes under the lateral arcuate ligament. Okay, so we've got the kidneys and the suprarenal glands. Now remember, these are retroperitoneal. And so if you're wondering what in the world are suprarenal glands, these are also just called our adrenals. So if you've heard of the adrenal glands, that's the same thing. All it means is that they just sit on top of the kidney. So I like to sort of jokingly call these the little hats of our kidneys. So these kidneys actually don't sit exactly in the same plane from the left and the right. The right kidney is actually just a little bit lower than the left kidney, and it's also smaller. Now, why in the world would we think that it would be smaller and lower? Well, if we think about our anatomy, we've got that big organ that sits in the way. So from the embryological development, you can look at it and sort of see the fact that, okay, when it's traveling upwards, and we're going to talk about embryo in a little bit, but when it's traveling upwards into its proper place, it's actually sort of being hindered by that liver. And so as it's moving up, it's actually going to be a little bit smaller and farther down. So I like to remember these two and to figure out where they sit in the body by I left at 11 to right from 12 to 3. And I've color-coded the two so you know which one's a left and a right. So I left, that's going to be on the left kidney. From 11, that's going to be rib 11 or T11. And then 2, that's going to be L2, which is the bottom portion of that kidney. And then right, that's going to be our right kidney. And then it starts at T12 or rib 12 to 3, and that's going to be L3 at the bottom of it. So remember, our kidneys are surrounded by peritoneal fat and enclosed in the renal fascia. On the right and left, I've included all of these all of these parts that overlay it, and so that way that you can look at something like, let's see, there's the stomach. If there's something that's, maybe wrong with the stomach and it starts, I don't know, like leaking something, and it gets through to the kidney or something, or like somebody gets stabbed pretty far, it goes through the stomach, what is the next organ that it might hit? Well, we know that the left kidney is going to be back there. So I included these so you can get like a sense of what is in front of these kidneys. Okay, so the anatomy of these kidneys, when you pick up a kidney and you look at it, you need to know if it's a right or a left. So the way I look at it is, if I'm looking at it from anterior to posterior, I think I need to see the vein, then the artery, and then the renal pelvis, which leads to the ureter. So I think of kidneys vape, anterior to posterior. So vein, artery, and pelvis. You also need to know the formation of urine. That's really vital and important to know. Don't get all into the little nitty-gritty details and think more complex than what is like on the slides, but like don't think of like physio, because that's going to come back later. But just for anatomy, you need to know it travels from the glomerulus to the renal tubule, to the collecting duct, to the minor calyx, to the major calyx, to the renal pelvis, and through to the ureter. And then, of course, from there, we get to the bladder, to the urethra, and now we're out as urine. Just make sure that you can maybe go into the model room, look at a model, be able to trace it, and just know that formation of urine, because that could be really an easy question for lab or lecture. The next thing that we need to talk about is this nutcracker syndrome. If you can remember back, we've talked about nutcracker syndrome before. We've talked about this SMA. If it dilates, it can compress some structures. We said it could compress the duodenum as well as the pancreas. So now we've got another structure to talk about with the kidneys. If it dilates, it's going to constrict blood flow returning from the left kidney to the left renal artery, and the blood will back up. So it can compress that left renal vein, because as you can see, the IVC is positioned on the right. So the left renal vein has to pass over the aorta, under the SMA, to the kidney. So if it backs up, we're leading to renal failure. What you'll learn in next block is that the gonadal vein drains into the left renal vein, and it can cause a hematocele, so scrotal swelling with blood on the left. But that's just something to look forward to. Okay, so renal stones, or kidney stones, or renal calculi. There are 3 most common locations of the stones: the uretopelvic junction, the pelvic inlet, which is the most common, and the entrance to the bladder. So the way I remember these is either where it exits or enters, or where it lies on a structure and kind of compresses. So as it's coming out of the pelvis to form to the ureter, that's going to be our first location. Our last location is entering that bladder. But then as it passes over the pelvic inlet, as it passes over the bifurcation of our external and internal iliac, it can also that's the most common place for a kidney stone to get stuck. So blood supply to the ureters are from our renal arteries, branches from our abdominal aorta, gonadal and common iliac, and also branches from our internal iliac. This is really important to remember, the suprarenal blood supply. So veins, really easy. We know that the IVC is on the right side, so our right suprarenal vein is going to drain straight into the IVC. And it's right in its name, so suprarenal vein. On the left, our left suprarenal vein, it can't go all the way over to the IVC. That's a pretty far distance, so it's going to drain into the left renal vein. And then, of course, we remember that the left renal vein will drain into the IVC. Arteries, there's going to be a superior, middle, and inferior. So it's actually getting a decent blood supply. So the inferior phrenic artery, remember we had talked about that as the eyes on our aorta man. It's going to give off a branch, which is our superior suprarenal artery. Coming straight off of our aorta would be the middle suprarenal artery. Now, that wasn't on our aorta man, but I like to sort of think of it as like a mustache on aorta man. And then our left and right renal arteries are coming, they will make up our inferior suprarenal artery. They'll throw off a branch to make that one. And they're kind of lower because the renal artery is going to our kidney, so it sort of makes sense that a branch could come up and give the inferior suprarenal artery. Okay, we've got some more lymphatics to talk about. So there's pre-aortic nodes and there's para-aortic nodes. So pre means before and para means around. So the pre-aortic nodes drain the GI tract, and then the para-aortic nodes drains all other abdominal structures and lower limb vessels, which drain into these nodes. So remember that the IVC is formed by the common iliac veins joining at L5, and the common iliac artery splits from the aorta at L4. And remember, it's bifurcates at L4, and then the vein is just one level lower. So we had talked about this before, the lumbar plexus, and then we had also looked at all of the muscles in the posterior abdominal wall. Well, here again are all of these nerves plus the mnemonic and their nerve roots. So in Ireland, good lads feel okay. Iliohypogastric, ilioinguinal, genitofemoral, lateral femoral, cutaneous, femoral, and obturator. And then the way I remember the nerve roots, if I can line up those nerves in order with the mnemonic, then I think of L1. It's like a pyramid. L1, 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 L2, L2, L3, L2, L3, L4, L2, L3, L4. And that just helps me remember what nerve root goes with what nerve. And you can look at the picture and see these nerves traveling over those posterior abdominal muscles. Here are the lumbar plexus cutaneous nerves and where they come from. I just want you to make sure that you look over these and know where these are located. So, for example, a patient comes in and they're complaining of numbness and tingling on their lateral thigh. And you have to figure out, what's wrong with this patient. They might also throw in something like to this question, like they're wearing a really tight belt, or, it's an overweight male. They might add that in there, but they may not. So what this would be that the lateral femoral cutaneous is actually being compressed. So that's why it's important to know these, because maybe their belt is pushing on it. So they might need bigger pants or something like that. Okay, so this is from Dr. Chestnut's lecture, and I stole some of his slides. So, like, to know about Dr. Chestnut, you need to know his objectives. Now, I don't always use the objectives when I'm looking at some of the lectures, but there's certain lecturers that I do look at the objectives, and he's got the objectives on the bottom of his slides, which goes with what slide it corresponds to. So it really sort of helps you. So like this one, for example, it says, discuss the strengths and weaknesses of the abdominal radiograph. So he didn't have it in his slide, but I went ahead and added it, what he said, to this slide. And this is actually one of our slides from year 2, because he goes back over a little bit of this. But it's really good to be able to like answer his questions, be able to answer those objectives when you're going back through it and reviewing. Okay, so x-rays are one of the initial imaging modalities for any skeletal pathology. So they're really good at seeing bones, but they're not really good at seeing tissue. So something like a kidney, that's going to be harder to see. Something like, my humerus, that's really easy to see. Metal, that's easy to see. But something like a piece of wood, like I got a, piece of wood jabbed in my arm, like I may not be able to see that because it's like organic matter. X-rays have really good imaging time. It's really quick. Availability is good, but also besides the poor soft tissue resolution, there is also some radiation exposure, although it's pretty small. As you can see, they've got the kidneys, spleen, and liver, duodenal cap, colic gas, and stomach. He's got that outlined, but they're sort of difficult to see. So I would be able to just look at these and know where they're located, even though they're hard to see, and knowing the advantages and disadvantages of an x-ray. So we've got the hepatic veins on a CT scan. Here is the left hepatic vein. Here's the middle. And here is the right. There's our IVC. And here's our liver. There's our esophagus. And it's just left to the label. There's our aorta. Here's our stomach. And you can see on the right side where this CT was taking place in the body. So just make sure that you can label these. Okay, hepatic veins on an ultrasound. So make sure that you can label these. Each of these parts, the IVC, the left hepatic vein, middle hepatic vein, and right hepatic vein. Now, this looks just like this picture. So if you can like start looking at this and figuring out, hey, okay, I know what these are. These are like the ears, here's the nose. It can really, really help you out. Okay. Here is the CT of the upper abdomen. And the kidney should be really bright. Remember, it's got water in it. Here's our liver. There's our spleen. Our stomach. There's that bright kidney. Our aorta. Our IVC. There's the adrenal glands that we had talked about. And here again is our adrenal glands. And this kind of looks like that wishbone, like he had talked about. And so since he's showing you 2 pictures of it and showing you this wishbone, that might be something that he might ask. There's our portal vein. Okay, so here's our pancreas on an ultrasound. So already labeled is our liver. And you're like, I have no idea. I see like an upside down smiley face on this picture. But don't worry. There's just a small amount that you need to really see. This is our splenic vein. Remember, it's really dark. It's got blood in there. So if you see this dark portion on this picture, the upside down smiley face is going to be that splenic vein, the smile. As it goes, it's almost like a comma. As it gets to the top of the comma, it's going to be our portal vein. And then everything right above it is going to be our pancreas. So be able to find that comma or upside down smiley face and be able to find that pancreas on ultrasound. So here is our Portahepatis, and that's going to be a region. It's really a region, it's not a structure. It's containing the portal vein, common bile duct, hepatic arteries, and then nerves and lymph nodes. And we've talked about this before, but just be able to find this on CT. So now we're going to talk about the biliary ductal system on an ERCP. So it's good to know what type of imaging this actually is. And so the snake-like structure is going to be our endoscope. And now we're going to label all of our ducts. So this is going to be our intrahepatic ducts. And then we're going to start labeling our right hepatic duct. And then our next one will be our left. And this is going to be labeled on the screen itself. It comes down to form the common hepatic duct. Here's our gallbladder. Remember, our cystic duct goes to it, and there's our cystic duct. As we travel down, it's going to become our common bile duct. And then our pancreatic duct goes from that to our pancreas. And then the common bile duct and pancreatic duct form together at our sphincter of Oddi. And so we're going to label each of these parts. And so this is sort of like aorta man, but instead it's on imaging. So this is a way that they could ask this. So here's our abdominal aorta. So we're going to start by labeling the celiac trunk and the branches coming off of it. Here's our splenic artery, and it's spiraled, remember that. Then we've got our common hepatic that's going over to the right side. Off of the common hepatic, we've got our gastroduodenal artery. We've also got our proper hepatic artery. Coming on down is the mouth of aorta man, which is our superior mesenteric artery, or SMA. Then we've got our right renal artery and our left renal artery. Here's our inferior mesenteric artery, which was the belly button of aorta man. Here's our leg, which would be the right iliac artery, and our left common iliac artery. So be able to label each of these. Okay, here's some blood supply to the bowel. So on the left side, we've got our superior mesenteric artery arteriogram. And on the right, we've got our inferior mesenteric artery arteriogram. So here's our SMA. Here's our middle colic. And remember that this is our MRI coming off of our SMA, so this is going up to our transverse colon. Here is our right colic artery. And at the bottom is our ileocolic artery, M, R, and I. Here's our jejunal and ileal artery and all their branches. And here's our IMA. So we've got a left branch, so this is the ascending branch of the left colic. Here is the descending branch of it. And right around here we've got our marginal artery. This is also called the marginal artery of Drummond. And then at the bottom we've got our sigmoid arteries. Here's another imaging. And so this is looking at our duodenum. And as you can see, this junction, as shown in yellow, and this is malrotation, which is not normal. And he doesn't really put any of the bad things that can go wrong on imaging. He's just going to show you the normals because you're still in the first year. As you go to second year, then you have to start labeling what goes wrong. Here's some mucosal patterns of the small bowel versus the colon. So remember that the small bowel has that plicae circularis, where the large bowel has the haustra. And the muscle that goes down the large intestine is the tinea coli. And so this could be super easy type of question in lab or lecture, where they show you a radiograph and they're saying, okay, what type of colon is this? Or what's this muscle that travels down this? Or the type of either haustra versus plicae circularis. The different types of folding. Okay, so let's get to some embryology before we call it a day. So this is the lateral plate, a mesoderm. So we've got visceral and somatic. So the visceral lateral plate mesoderm becomes the smooth muscle of the GI tract, where the somatic becomes the parietal peritoneum, muscles, and dermis of the body. So the midgut development, it's going to be a loop connected to the umbilical vesicle by the Biliary Duct, and this is the area of the future ileum. Okay, so stomach rotation. Now, Dr. Gassler really loves rotation, and it is really important anyways in embryology. So you need to know the number of degrees that certain structures rotate, because they don't just start out in the position, developing, and end up in that same position, but they start rotating around an axis. So it's important to know how much they actually rotate. So if we look at this picture of the stomach, we can see that there's a ventral mesentery and a dorsal mesentery. And so in week 4, it's going to rotate 90 degrees clockwise around this longitudinal axis. So this longitudinal axis rotation and then a ventral dorsal axis rotation is going to result in the lesser curvature and the greater curvature. So the ventral border moves to the right, so know which one goes where. So as you can see in the picture, the pink color is ventral or right, and then the blue color is dorsal or left. So know which goes with what. So the ventral moves right, that's our lesser curvature, and then our dorsal border moves to the left, which is our greater curvature. Okay, so midgut rotation. This is probably more important than the stomach. So the midgut rotates 90 degrees counterclockwise on an axis of the SMA. So we've talked many times about that SMA. That's our mouth of aorta man, and our midgut is rotating around it counterclockwise 90 degrees. Then the midgut is going to rotate around another 180 degrees. So if we add these up, that's going to be a total of 270 degree rotation. Remember, in the stomach, we said that there was a 90-degree rotation. Midgut, there's going to be a total of 270 degrees. So I would know that it was counterclockwise around the SMA and that it's a total of 270 degrees. There's some anomalies. That's going to be the volvulus, which is our twisting of the intestines, or an umbilical hernia. So as you can see in the picture, we've got this twisting that takes place. Our intestines come out, but then they push back in. into this. And so just make sure that you can kind of see that in your mind, or that you know that if it doesn't rotate and twist enough, you can either have volvulus or an umbilical hernia. And just hernias are where that there's going to be like an outpouching with intestines inside. Okay, the rectum and anal canal. So we've got this terminal hindgut, and if you can see it on the picture, you can see the terminal hindgut and you can see the allantosis. And then they're sort of coming together to form the cloaca. So as they form that membrane, there is a urorectal septum. And it's going to start separating into two compartments by the ridge of mesoderm. So there's two anomalies that we're going to talk about. There's persistent anal membrane, which is the clonal membrane doesn't break down overlying the anal canal, and so the rectum ends in a blind pouch. So why would that be a problem? Well, if there is no hole for the poop to come out, then we're going to have like backup, and what's in feces, lots of bacteria. So we're going to end up having infection and no way for this for our feces to escape. So it would have to be a surgical intervention. Another thing is anorectal agenesis, which is the most common anomaly, which is a fistula between the anal canal and either the urethra, vagina, or bladder. So all of those feces are going to be leaking into the urethra, vagina, or bladder. So we're going to start having problems like bacterial vaginosis or UTIs, or all of that bacteria is getting into other organ systems that we do not want to get into, because we just want to make sure that those are, clean. Only urine is traveling, through our bladder and urethra. So we don't want some infection getting in there. And then we've also got our renal development. So we've got urogenital ridges, which are cells of mesoderm that proliferate and extend from the cervical to our sacral regions. And then we've got our nephrogenic cords, which are longitudinal columns of cells within the urogenital ridge from which the kidneys and the ureters will develop. So there are three types. We've got pronephric, mesonephric, and metanephric. It's really important to know where these places are located. So I think of pro as sort of being pre means before, but pro sort of is near the top. So pro is going to be in the cervical region. Mesonephric, I think more of, how like our mesoderm is sort of our muscle and those types. So I sort of think of it as in the middle. So we've got mesonephric, which is thoracic and our upper lumbar. Metanephric is going to be below our meso. So our metanephric is going to be our lower lumbar and our sacral levels. So our metanephric diverticulum is our ureter, renal pelvis, calyces, and our collecting tubules. So our major things coming straight out of that kidney onto our ureter. Then our nephrons develop from the metanephric mesoderm cells. It's important to know this term allantosis, and it is what becomes the median umbilical ligament. So, for example, if they were to tag the median umbilical ligament, which we have already looked at today, they may say, what is the embryological, or where did this structure come from embryologically? And you would put allantosis. So thank you. Email me if you have any questions.